is, let me say that there are different dry needling techniques. There is not a big difference between dry needling. You can only dry needle a patient a couple of ways. For example, you could dry needle passively. So in other words, you stick the needle into the muscle, don't really find the exact point of the pain. The patient just says, my shoulder girdle is pain, I have pain up over here. You say, okay, fine, I'm going to needle you. You put a couple of needles in and you leave the patient. That is very passive, ineffective dry needling. You're going to be getting the central release of your natural endorphins, but you're not going to be locally releasing the trigger points in the muscle because you're just needling generally. What we like to teach is as accurate as possible, safe dry needling. So whether the pain is over a risky structure, for example, the upper quadratus lumborum that lies over the kidney, or whether the pain is in the trapezius muscle that overlies the apex of the lung, you can accurately and effectively deactivate that pain by sticking the needle into the trigger point in such a manner that the needle stays in the muscle and doesn't go deep into the lungs or into the kidney. We do that in a number of ways. Let's take, for example, upper quadratus lumborum fibers. If you want to be accurate, you want to needle up a quadratus lumborum, you know the risk associated with it. You can reduce that risk, number one, by doing two things. Firstly, if you hit the 12th rib, if you palpate the 12th rib, you hit the 12th rib, and you determine the depth of the 12th rib, right? Then that is the approximate depth of the upper quadratus lumborum fibers. So then we can accurately needle QL without going into the kidney. The same around the chest. If we're needling the rhomboid muscles, needling rhomboids, levator scapula, lower traps, upper traps, serratus anterior, pec major in front, all have an element of risk of the needle going into the lung. That can happen if you take a long needle, a needle that's too long, and your needle goes through the intercostal space, and you don't realize that you're needling too deeply. Then the needle is going to go into the lungs, you're going to cause a pneumothorax. However, if you use the ribs around the chest cage, the needle can be protected from going into the lungs by using the backstop of the rib. Before you use the ribs, you have to do two things. Number one, you have to estimate the depth of that rib before you try and hit it. Can you imagine if you try and hit the rib and you miss the rib and you go into the lungs? What's the point of trying to hit the rib if you go past the rib into the lungs? So you have to estimate how deep that rib is first, so that if you're missing the rib, you're not going to go past the rib. Okay, so whilst there are a couple of different techniques, what we do on our course is we try and be as effective as possible in needling directly to the pain in the muscle, but at the same time, we are highly focused on safety, highly focused on not putting the needle into a visceral structure, and teaching you every single muscle of the body which is associated with some degree of risk, how to avoid that risk by having good anatomy. Are there any more questions, or can I show some of you guys a couple of videos so you can see needling in action for some of the muscles? Should we do that now? We've got 15 or 20 minutes left. Okay, so this is an introductory course. So most of you guys are new to needling, so I want to show you some of the techniques. I'm going to call up some files here.
Craig?
I'm going to show you the lumbar spine.
Craig?
Yes?
Yeah, I have a question. You mentioned about the strengthening of the exercises. Would you introduce a strengthening exercise on the same session? Because the dry needling course I have done, like for example, the patient goes for running, you tell them wait for 24 hours, then resume your exercise. So what about the strengthening exercise? You introduce it on the same session, or you will wait for 24 hours, or how you would, what do you suggest?
Everything about needling, everything is very dependent on the patient's condition, the patient, where in the pain spectrum they are, or where in their rehabilitative recovery spectrum they are, and also how well do you know your patient. In other words, can you advise your patient to do something confidently, knowing that they're going to experience a little bit of discomfort, but you know that they're confident that they're going to do it because you know that it's not going to cause a deleterious effect, and they're going to be okay with the discomfort that they're experiencing, for example, if they do some rehabilitation after needling. So I can't say just straight off, if you needle your patient, don't do any exercises, because it depends on where the patient is in their recovery, and depends also on how you needle. If I needle very, very gently and I'm not going to cause severe microtrauma, I can then take my patient through a series of rehabilitation exercises. But Naima, what I would probably do is I would probably do those exercises first and then needle them afterwards.
Mhm.
Because in most cases, if you're doing rehabilitation with your patient, they're probably somewhere close to, further down the line of between acute and chronic. They're probably maybe 10 days, 2 weeks, 3 weeks down the line in their injury. So they're almost on the road to recovery and they're starting to do their rehab. But what I won't do is, for example, a professional sportsman or even a weekend warrior, I won't aggressively needle their calf and then encourage them to go to the gym and do calf raising exercises. I'll ask them, right, okay, what is your plan for today? What are you doing for the rest of the day? Because I want to know, because I've needled your calf very aggressively. I want to know that you're not going for a run for 5 or 10 kilometers. I want to know you're not going to go do sprint training. I want to know you're not going to go to the gym and do calf raises, because that is going to get them back and aggravate the calf muscle. If they say to me, no, I'm thinking of going to the gym, but what I'm going to do is I'm going to do upper body today, I'd say, okay, fine. Only do upper body, because I've been very aggressive with my calf needling. If you go and do calf resistance training, you're going to aggravate what I've done, or you're going to tear that muscle.
Excuse me, sir.
Yes, go ahead.
Okay, what about if he just walk out like cardio, simple cardio, low steady state?
That should be absolutely fine. So, for example, if I've needled quite aggressively, and my patient then goes for a 1 kilometer walk along the beachfront, which is what they do on a regular basis, that should be fine. But I always tell my patient, let your soreness be your guide. So if after today's needling you feel a little bit more sore and bruised than normal, don't aggravate that. Maybe rest it for today, and you wake up in the morning and you feel better.
Okay, thanks a lot.
Dr. Craig, can I ask one
Yes.
question, please?
Yes, Osama.
Yeah, we have experiencing chronic cases for the low back pain. When you sometimes touch the low back pain, you feel like myofascial stiffness or problem, a big one, just like the size of your hand. All right.
Yeah.
I don't know if for sure for 30 years experience you have experienced that, yani, for sure. Does the dry needling gives a good effect with these people or not?
The general answer is that dry needling is effective for myofascial pain. Okay, if that is exactly what we're dealing with. Sometimes the diagnosis comes to us from the specialist, myofascial pain, and we treat them with needling, and it doesn't get better. And therefore, the pain might be coming from somewhere else, or it could be something wrong with the muscle that is not going to respond to needling. There could be an underlying systemic illness that is presenting with pain in that muscle or other muscles. So, for example, with rheumatoid arthritis or with Crohn's disease or with any of those systemic kind of conditions, your needling is not going to be that effective in the muscles if the patient has pain as a result of their systemic illness. Okay, what I'm talking about here is myofascial dysfunction or musculoskeletal dysfunction where the muscle has been injured and it's been injured from some specific type of trauma. And now, the trigger point that develops is going to respond to the needling because the muscle is wanting improved blood flow, because the muscle wants that hypercontractility to be deactivated. You could deactivate that with myofascial release. You could deactivate that with acupressure. You can also deactivate that with needling. And sometimes the needling is more effective because the other forms of treatment are non-direct treatment. You're treating through the skin with your pressure. You're creating changes in the muscle with your indirect pressure of your hands or your fingertips. Whereas with needling, the efficacy of needling, I think, when used properly, is better because the needle is going into the muscle at the cause site of the injury, and it is physically changing that pathology within the muscle tissue. Just to get back to your point, if it's a condition of the muscle that is going to respond to needling, it's going to work provided you're needling in an adequate way with the correct size needle, and you're not. The thing you need to remember is, and I always get back to this, is if your patient comes to you acute, needle softly. If your patient comes to you with long-term pain of muscle origin, you can needle a bit more aggressively because you need to promote the blood flow and you need to get the muscle working. Sorry for the long-winded answer.
Thank
Any
you.
more questions?
Excuse me, sir.
Yes, sir. I have a
Yes.
question. Hello.
Ahmed.
Hello.
Yes, go ahead.
Yes, sir. Which technique is better for breaking trigger points? Static techniques or dynamic techniques?
For breaking trigger points, they can both be effective.
Yes, sir.
The static passive technique is more effective, especially if the patient is very sore. If the patient is in a lot of spasm, then you're going to needle them gently and passively. If the trigger point is very chronic and has been there for a long time, weeks, for months, and now they're only coming around to treatment, you can treat them a bit more aggressively. And it's going to take longer to get better because it's been around for a long time. Because the lack of blood flow and the weakness in the muscle has got to be reversed. And the reversal process is often dependent on your technique of needling. If you needle indirectly and just passively, that response time, the chronic condition is going to take much longer. If you needle directly, more aggressively, you're aiming to get as many twitches as possible, the patient's response time is generally going to be quicker. Any more questions? Can I show a video?
Doctor,
Yes.
so the muscle twitch should be happening, right?
That's what we're aiming for. If it's a trigger point, yes.
Okay, thanks.
Yeah.
Excuse me, sir.
Yes.
According to calcium accumulation in some muscle, does this lead to increased activity of actin and myosin, so it doesn't work adequately? So that's makes the trigger point.
That's the understanding. So if you imagine one cell, right, one muscle cell contracts with the presence of calcium, which changes the shape of tropomyosin, which allows actin and myosin to bind together. The calcium doesn't affect actin and myosin. Calcium affects tropomyosin, which the shape of tropomyosin changes to expose the binding site for actin onto myosin. Then when the calcium is removed out of the cell, tropomyosin goes back to its normal shape, actin and myosin detach. That's the sliding filament theory that is generally accepted for how muscles work. So if there's a buildup of calcium, and now you have a hypercontracted state of the muscle, because the muscle cannot relax because the calcium is stuck in the muscle, we come along with our needle and we stick the needle into that band of hypercontracted tissue, and we try and get as much of those hypercontracted tissues to deactivate with the twitch response. The twitch response is still unknown as to why a muscle twitches with the needle. The theory is, not the proof, theory is, number one, it's the physical presence of the needle is rupturing those cells, is allowing the calcium to escape, and the actin and myosin are detaching. That's the one theory, okay?
Okay.
Other theory is that when you stick the needle into that part of the muscle, you get a spinal reflex reaction from the muscle through the spinal cord back to the muscle, which causes the twitch. And that the twitch is the muscles detaching or deactivating, relaxing, and that relaxation improves the blood flow to that area, which results in the muscle healing. However, I am a little bit more stronger in my belief in the spinal reflex. Sometimes, all right, sometimes you get a twitch in the muscle, not near to the needle. How does that happen? If I stick a needle into the quads and the muscle twitches 5 inches away from that needle, how is that needle causing that twitch in another part of the muscle? And I've even seen another muscle twitch when I've stuck a needle into, let's say, for example, vastus lateralis, and I've seen vastus medialis twitch. So I'm thinking, how did I physically get twitch in VL, also in VM? And my explanation, I'm not a researcher, I'm a clinician, my explanation is maybe more stronger on the spinal reflex being a result causing the twitch than the actual physical presence of the needle. But that needs more research, and there is a Saudi Arabian physio who will be starting his PhD, and he's going to be doing more research on the actual cause of the twitch and what is happening when the needle goes into the muscle and causes the muscle.
By the way, I'm Saudi.
Oh, congratulations. That's nice. We're in Saudi.
Jeddah.
Cool. Very nice. Right, can I get to the videos, guys? We've got a couple of minutes left. What is the time? 7 o'clock. Can I show some videos? Right, let's share
Can I
screen.
ask you?
I'm going to show a video now, and then you can ask a question after that. So here's the video.
I have a question.
After video, okay? After video. Let him complete. Huh?
I'm going to get to the.
Okay.
I'm just going to get to the actual needling. So I'm just describing the anatomy of the spine, the thoracolumbar spine. I'm needling quadratus lumborum. Just getting to the point of the needling.
Everybody can enlarge the screen. Could be
right, here we go.
more clear.
Here we go. So this is for erector spinae. Quite a big patient. I've got a 30 mil needle, and I'm just needling erector spinae. The needle is staying in the muscle. Needle cannot go deep through the erector spinae, through quadratus lumborum into the kidneys. But the next muscle we're doing is multifidus. All right, so this is multifidus needling. There we go. The needle's gone in. The needle is directed medially towards the vertebral column. There's a reason for that. You don't want to go down vertical towards the spinal nerve roots that are coming out between the transverse processes. So we aim the needle towards the vertebral column, also because that is the bulk of the multifidus muscle. Nice tap, 40 mil needle, going all the way in. And if you needle multifidus a lot, you'll know that it's a very reactive muscle. It often goes into spasm, or it often feels very stiff. I'm going to go on to quadratus lumborum. So this is our safe area. That's where the kidney is there. So the needle below the kidney. There's L3. That's probing and fishing when I'm moving the needle in and out. Once again, that's probing and fishing there, in and out into the muscle, a subtle change of angle. So now I'm needling the medial fibers of quadratus lumborum towards the attachment onto the transverse prolus. Okay. Any questions? Any questions on that technique, the size of the needle, the direction, the angle?
Okay.
Doctor, please, I want to ask.
Go ahead.
Excuse me, sir.
Amir, yes.
Please,
Is local-
first, thank you for your nice presentation.
Sorry, Amir's asking a question, guys. Go ahead, Amir.
Doctor, is much every time I am doing dry needle, local
Yes.
twitch response must happen.
Well, that's what you're looking for. Yes, essentially, every time you're needling a trigger point, you're looking to get a twitch from that trigger point. That is a good sign that you're in the trigger point in the muscle if you get a twitch. Correct.
So if I didn't get local twitch, am I doing wrong?
No, not necessarily, because sometimes you're not needling a trigger point. So you mustn't expect a twitch from the muscle. If you're needling scar tissue, if you're needing fascial adhesions, then you're not going to get a twitch. If you're needling the tenoperiosteal junction or the tendon, you won't get a twitch.
But if I'm
If you're in the
needling
muscle, the trigger point, you essentially want to aim for getting a twitch. Correct? Yes.
Thank you.
Pleasure.
Excuse me, for multifidus muscles, which direction is the best? Caudal, ventral, and central is the best, or just we will apply on the in a central position
for multifidus? Yeah, we're talking
for
about the lumbar spine,
caudal,
right?
central.
Yeah. What we do is we teach that you needle multifidus in a medial superior direction. So you're going with the fibers. This is the only time we teach you going with the fibers to try and keep the needle in the same band of multifidus. Remember that bent needle. The bent needle occurred when we needled in a medial direction from lateral to medial, and we went through 2 or 3 different sections of the multifidus muscle, and they reacted differently, and they caused the needle to bend. So now we teach needling in a medial superior direction, so we get as little bending or reactions of the multifidus between the different groups. Okay, that's a nice question. Thank you for that question. Any more questions, guys?
Yes,
Excuse
I have a
me.
question.
Saeed, go ahead. Saeed Atia.
It is had an evidence in sports injury.
Dry needling in sports injuries.
Yes.
Yes, absolutely. For sure. Yeah.
Strength exercise performed before or after dry needling. In this case,
it's probably better to do your exercising in your rehab before, all right? But it depends on what you're needling. If you're needling your accelerator muscles, then you mustn't do
Mikey,
heavy
please.
resistance exercise afterwards. If you're needling the trapezius muscles, but the patient's going to do a leg exercise afterwards, that's fine because you haven't needled the legs. Yes.
Doctor,
next question.
Yeah, doctor. Which position and the direction is the best for the middle fibers of the quadratus lumborum?
For the middle part.
Yeah.
Okay, we're talking lower quadratus lumborum below the level of L3.
Okay.
Okay, because that's not going to hit the kidney.
Okay, we will, before applying the needle to the quadratus lumborum, which test we will apply, to confirm it is, the trigger point, inside the quadratus lumborum, or this is the problem of the quadratus lumborum.
Yeah. So in other words, how are you going to diagnose that it's quadratus lumborum causing the pain, right? That's what you're asking, right? I do a very simple test. I know it's quite rudimentary, but it's quite simple. I get the patient to stand with their legs slightly apart, and I do side flexion. Because often if you've got a stiff, tight quadratus lumborum, the lumbar spine does not articulate away from the pain, away from the quadratus lumborum pain, because the quadratus lumborum pain is holding, stiff and it's tight. So that's the one thing I look at. The other thing I do with all my patients is I use a very slight oily massage as a means to find the pain in the muscle. Because if you give your patient a massage, you can feel the change in tension in the muscle where the pain is coming from. And then if I can reproduce that pain, that's where I stick my needle into. So just two simple things. Number one, movement test, side flexion, because if the quadratus lumborum on the opposite side is locked and holding, you won't be able to side flex and the back won't move properly. And the other thing is to give them a very mild massage. Also, you've got to check, if your patient's coming in with leg pain or bum pain, a referral of pain, you've got to exclude the disc, you've got to exclude the nerve roots, you've got to exclude the glute muscle, you've got to exclude other structures that could be causing the patient's pain. Next question.
Which test is good to confirm the quadratus lumborum, for the diagnosis of the quadratus lumborum problem? In standing, we will perform the side bending, or we will, in a side lying position, we will apply the resisted hip abduction.
Well, you can do both. You could test the strength of quadratus lumborum in side lying, because you could get them to do a side flex on the bed. What I'd like to do is I just like to look at how the quadratus lumborum, how the lumbar spine is working, and what that quadratus lumborum is doing to the lumbar spine. That's what I like to look at. It's just what I've developed over, and I also do the stalk test, because if the quadratus lumborum is stiff and tight and in a shortened position, they're going to have a positive stalk test on that side. The sacroiliac joint, the PSIS, is not going to drop down when you got them standing on the opposite leg. It's often a good sign of a locked quadratus lumborum. And then when you stick the needle into the quadratus lumborum, it reproduces the patient's pain immediately. The cure refers either to the side of the hip or deep into the buttock muscle. The superficial fibers into the side of the hip and the iliac crest, and the deep cure muscles into the buttock and the upper thigh.
Can we approach the quadratus lumborum from, one technique is from the posterior to the anterior, and can we approach from the, from the side of the, trunk?
Yeah, There's two techniques. There's an easy way with your patient in prone and you needle in a vertical direction.
Yeah.
And there's a difficult way with your patient in side lying. Then you needle down the length of the muscle. So if this is quadratus lumborum and the patient is lying prone like that, needle down through quadratus lumborum. If you put your patient into side lying like this, now you have to needle this way along the quadratus lumborum muscle like that. That's the tricky way because you have to find the specific line of the muscle. So we teach that technique on our advanced level 2 course. We teach the prone technique on our level 1 introductory course.
Thank you.
Pleasure.
So, doctor, on fishing technique.
Yes, fishing.
Yeah, in fishing technique.
Yes.
Do you prefer the needle to be perpendicular or cross the fiber or with the fiber?
What I do is I always palpate with my fingers for the band. And then I always put the needle in the direction of my pressure of my palpation. So if my palpation pressure is vertical, needle goes in vertical because that's going to be as accurate as possible to hit the band of what I was palpating. If I'm palpating from the side, let's say I've got the QL muscle over here like this, and I'm palpating from the side, not downwards, my needle goes in that same direction as my palpation because that's going to ensure my accuracy of hitting what I was feeling.
Thanks.
The direction indicates the
direction of the needle, first and foremost, is in the direction of the band. Secondly, you may change your direction if you need to be safe and needle away from, for example, kidney. So let's take, for example, quadratus lumborum. If I'm needling quadratus lumborum in prone, patient lying on their tummy, the patient's pain is at the level of L3. Then I'm going to angle my needle towards the feet, away from the kidney. Be safe. That is a specific reason that I'm angling my needle away from the lower pole of the kidney.
You mean caudal?
A caudal direction, correct.
Yes.
Excuse me, sir.
Yes.
What if I had dry needling for me, and have to exercising after maybe 12 hours? Is it okay if I feel okay? If I feel there is no dumps, right? Like dumps?
If you've had needling and then you don't have any ill effects of your needling, you don't feel muscle soreness, you don't feel stiffness, then and it's 12 to 24 hours later, then you're probably okay. You as the patient are probably okay to go and exercise. But then I would also tell my patient, while you're exercising, right, listen to your body. If it feels like it's getting a little bit stiff, something's happening. Don't go through it. Stop. Don't make it worse. Because if you exercise your acceleration muscles, your quads, your calves, your biceps, if you upper body workouts and that, and you exercise them after deep aggressive needling, going to damage those muscles further, and that's not what you want to do. So the advice to your patients is always very important.
Excuse me.
Can we perform active range of motion while needling the patient?
Sorry, can you repeat that?
Can you perform active range of motion exercise while we needle the patient?
Can, yeah. But you do it in for a very specific reason. And
what's this reason?
The reason is that the patient's got chronic scar tissue, and nothing has helped that scar tissue to heal. And it's the scar tissue that is stiff and tight that is preventing them from being able to sprint, or is preventing them from being able to rehabilitate the muscle back to normal strength. because of the scar tissue. So you can needle the scar tissue normally, and if you want to make that needling more aggressive, you want to increase the effects of the needling, you can add to that some passive movements or some active movements while the needle to look at your patient and you have to decide what size needle do I have to use to get through all this fatty tissue. And you're probably going to use a 50 or a 60 or a 75, depending on how big and fat the patient is. If the patient is skinny and a lot smaller, you're probably going to use a 40, at most a 50. But what we always teach is that when you're needling a deep muscle, so in other words, if you've got a superficial muscle and you've got a deeper muscle, when you're needling the deeper muscle, you can know when your needle is in the deeper muscle because of the change of resistance in the needle from the deeper muscle. That's a skill that you need to acquire by lots of practice, by knowing your anatomy, also by being able to look at a patient and knowing the size of the needle you're going to need to use is going to get deep enough into the deeper muscle. And when you're in that deeper muscle, the needle feels stiffer than the superficial muscle.
Excuse me.
Go ahead.
Thank you.
Excuse me.
Go ahead, Osama.
Dry needle effective for cases old facial palsy or no?
Sorry, I didn't get the end of it. Cases for what?
Cases old facial palsy. Dry needle effective with these cases?
I'm not understanding you.
Doctor,
does
It's
anyone
telling
else?
facial
he is
palsy.
ask-
Is it
Bell's
effective?
Facial
palsy.
palsy.
Yes. Osama, everyone asks that question. That's the most common question to be asked. So it's a good question. I'm going to answer that in two parts. Firstly, I'm going to say that dry needling is not going to stimulate the nerve recovery. Okay? It is up to the nerve. We're not going to use dry needling to needle the nerve or to stimulate the nerve recovery because it's a demyelination of the protein of the nerve, often associated with an autoimmune type of reaction or a stress kind of reaction. However, my second part, what I'm going to say is that if the patient has pain in their facial muscles as a result of the flaccidity, looseness of the muscles hanging, stretching, you can needle those muscles. You can try and reduce the patient's pain. However, you are not going to be highly effective. You might be a little bit effective. You're not going to be highly effective, in my opinion, my experience. Okay.
Can it effective in stroke patient or not?
A good question. Yes and no. Yes, in the short term. Yes, for your hypertonic patients. Yes, for your increased tonic patients. You needle the muscles that are in spasm. You're trying to effect central control by the stimulation of the needles peripherally in that spasmodic limb. The effect of the needling is not long-term. My neurological colleagues who work in neurology and use needling on their hypertonic patients say that the needling is effective, it's positive on the short term.
Excuse me.
How are we? We're at 7:25. Where is my host?
Excuse me.
Have a special technique for this or
So
normal?
You do passive needling. You take maybe 3 or 4 short needles and you just needle the patient superficially.
Excuse me.
Go ahead.
Can I ask about iliotibial band needling, please?
Of course you
Iliotibial
can.
band.
Yes, Naveen, yes. What do you want to know about iliotibial band? What is your question?
If I have a trigger point in the iliotibial band, the best position for the patient and the best technique for needling. Yeah, please.
Okay, firstly, Naveen, don't turn your microphone off. I'm going to ask you a question first. Will you find trigger points in the iliotibial band?
What? Please again.
Are you going to find trigger points in the ITB, in the iliotibial band?
Most of the patient with patellofemoral pain or post-patient TKR, they have iliotibial band trigger points.
Okay, right. Let me
near knee joint.
Let me qualify that for you. Firstly, I have trigger points in the quadratus muscles under the ITB, or in vastus lateralis, because the ITB is fascial tissue. It's not a muscle. It's not, doesn't have contractile elements. So the tightness of the ITB is just the fascial tissue tightness in the ITB. The trigger points lie in the muscles underneath. So when you needle the ITB and you needle through into the muscles, you are deactivating the trigger points in vastus lateralis. Okay. What you need to do for the ITB tension is you must needle tensor fascia lata and glute max, because these two muscles insert into the ITB. They control ITB tension. So if you want to relieve ITB tightness, needle TFL and glute max, and it works very well for iliotibial band friction syndrome at the knee, for generalized ITB tightness up the thigh.
Thank you, doctor. Thank you.
Pleasure.
Doctor.
Yes.
In rhomboids cases, can you use dry needle after deep friction massage?
Okay, so why would you needle after you've deep frictioned? Because your deep friction massage is going to cause lots of trauma. There's nothing that says you can't. It's not a contraindication. But if you think clinically, if you deep friction the patient for 10 minutes, you're going to cause a lot of trauma, a lot of bruising. That's going to be the similar outcome to aggressive needling. You either do the one or the other. That's my opinion. I would never go and do deep frictions on a tissue and then go and needle it at the same time. I might go and needle around the area, the spasm in the other parts of the muscle. I wouldn't do deep frictions and needling. I would do one or the other because I want to know which one will work better.
Yeah.
That's why I would do them individually.
Mr. Craig,
we run out of time.
I want you to give them small advices how to be a certified dry needling practitioner, and how to have the right way for serving your patient safely.
Yeah. Okay, so become certified as a dry needling practitioner, and I can only speak from our own institute, the Dry Needling Institute, which is our courses are run by Club Physio, our company, and we do a level 1 over 3 days. We do a level 2 over 3 days. On the level 1 course, you learn all the common muscles. So traps, rhomboids, lumbar spine, cervical spine, upper limb, and the lower limb and the glutes. You do not get certified after completing level 1, but you are given permission to use needling on those muscles that you've practiced and that you've been taught. And we encourage you to go away and to needle. Then you can come back and you can do the level 2 course. And the level 2 course teaches you how to needle the tricky muscles, the difficult ones, all right? The ones deep inside the face, the ones in the skull, deep scalene muscles that attach to the ribs, the serratus anterior over the rib, the minor deep onto the chest, deep external rotators, the deep calf where the tibial nerve and artery are. So we teach you all those tricky muscles, and then on the level 2 course, you take a practical exam. And we assess your needling skills, and we make sure, number 1, you are safe, and number 2, you are effective. If you pass the exam on level 2, then you can take the dry needling certification online course, which is a true, false, yes, no, right, wrong course on our website, which you have to pass with 70%. And after completing and passing both the practical exam and the theory exam, we then certify you as a competent dry needling practitioner. And that is certified by the Dry Needling Institute, which is our institute, whose courses are run by Club Physio. There are some other companies that do certification after just an introductory course. I don't think that you can be certified competent after just doing an introductory course. So the certification process should be an examination process, and it should be both practical and both theory. And you should have needled all the muscles in the body before you could be certified competent as a dry needling practitioner. That is our process, Ahmed, that we'll go through.
Excuse me, doctor.
Yes.
I want to ask one question.
Sure.
For practice, which company you will recommend that needles? Which company you will recommend for the needles?
For the needles.
Currently, I'm using this APS needles for my clinical practice.
Yes.
Okay.
That is a Spanish product.
Yeah, Spanish product. Which needle you will recommend?
Yes. Well, obviously, I recommend our needles because we have our own branded Club Physio needles. But I don't want to push my product. I would say that the 2 needles that I have used before that are fine, that are good, are Quarto and Serum. The important thing about the needle is that it must glide smooth through the muscle. You must have no friction on the needle. You must be able to feel the needle in the muscle and be able to pick up the tension. If the needle is shuddering like that, it's a terrible needle. It's too much friction. It's not allowing you to feel the quality of the muscle and when you're in the right area, when you're in the trigger point or when you're in the spasm, or even when you go from a superficial muscle to a deeper muscle. You must be able to feel that change in tissue tension. So we've had our own needles manufactured now. We've had only positive responses, no negative responses at all. We only use our needles on our courses. We sell our needles on our courses. Lots of people come back and buy from us. But if you don't have access to our needles, APS, the thing I like about APS is that they have good sizes and good variety of sizes. And Huato and Siren. Siren is Japanese and Huato is Chinese. I've never had problems with those needles. Ahmed, I think we're out of time, eh? 7:30.
Yes, as you like, and we take some of your time. Very thankful for you, and you are appreciate your what you are doing with us. You are usually great, And I tell one word: you are a Caesar of dry needle.
Thank you very much. Thank you. I just want to I want to finish up by saying that during this lockdown period, there are no practical dry needling courses taking place because no one is traveling, no one is teaching, and so obviously everything has moved online. And so what we've decided to do is we're taking our review course online. So if you are needling at the moment and you've done a needling course with Jan Dommerholt, who is the father of dry needling, or with Optimal Dry Needling Solutions, all friends of mine, all teach excellent courses. If you've done a needling course with someone else and you want to have a refresher course, we are running online refresher courses. And on Monday, Tuesday, Wednesday, and Thursday, we are running the module 1, 2, 3, and 4. We're running it with Ahmed. And it's a 3-hour review. So I will show and demonstrate how to needle, for example, the upper quarter or the lower limbs or the spine or that type of stuff. So if you're interested in something like that, get a hold of Ahmed, like he's gotten hold of you for this introductory course. Okay, guys, thank you very, very much. I've really enjoyed it. The response has been amazing.
Thank you so much.
Thank you.
It's a
Thank you
pleasure.
so much.
I'm going to end the meeting now. And I wish you guys all the best during this period and hope to see you on one of our courses in the future.
Thank you so much, Dr. Craig. Thank you so much.
Pleasure. 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 Go well. I'm going to end the meeting.
Thank you,
just
Doctor.
press leave
Thank you.
meeting now. Cheerio. Bye, guys. Thank you. Bye.
Thank you, Doctor.
Bye.
Bye.
Thanks.